into our concept blending. So these are your modes of transmission, your sexual, parenteral, perinatal. So remember I told you it crosses over the placenta. So you need to do your prenatal teaching. HIV is now part of your prenatal screening test. Now, one time you had to sign a consent to have it done. Now it's just an automatic part of your prenatal test. That's why prenatal care is so important. Healthcare workers, we're exposed to everything. So that's why you guys are getting the best. You glove up for everything. You glove up for everything. You glove up for everything. As a wee baby nurse, we were just taught to put on gloves when you knew you were going to come into contact with blood. You'll see some nurses who, even though they know the danger, they won't put on a pair of gloves to save their own life. But when they were raised up as nurses, none of this stuff was even, known about or talked about. So just through time and research and trending things that we come to our PPE and universal precautions. We treat everyone as though they have something, even if they don't. You'll have some persons who say, I'm HIV positive, or I have hepatitis B, C, whatever it is. You learn all about those too. Please put on your gloves. So those patients are more concerned about you than themselves. So we kind of talked about teaching as sexual mode of transmission. One thing you need to know are the ABCs. This is what the CDC states that we should be teaching. A, what do you think A is? Abstinence. That is your only 100% absolutely positively sure way never to get HIV, STIs, and not to have any children. Or produce children. Be faithful. C is your condom. And what do we say that condom must be?
Latex.
Latex or polyurethane or whatever the alternative is, okay? I know your book may talk a little bit about spermicides, germicides, or something like that. None of those things kill the HIV virus. None of those things do that. The only protective barrier you have besides abstinence is going to be your condom, okay? So write that down. I'm going to separate y'all.
I was writing down what you were saying.
Spermicides do not kill the HIV virus. Your only protection is going to be abstinence or a latex or polyurethane or whatever they got out there. As long as it ain't an animal skin, I think you're okay. Parenteral. So for us as healthcare workers, that's when we're starting IVs, when we're giving injections. There's also a caveat to that. You have your IV drug users. Back home, we had a needle exchange program. Oh my God, people were up in arms, especially those of the upper echelon of society, because they felt as though we were doing what?
Encouraging.
Right. If they come down from River Hills and Whitefish Bay and off the lakefront and actually, converse with regular society, they will understand that we are saving lives. I want you to bring me your dirty needles. Yes, I will give you clean needles. What are we? We're decreasing the chance of not only HIV, but you have hepatitis B, hepatitis C, D, E. I don't even know what letter of the alphabet we are on, okay? So we're decreasing that. So not only are these people IV drug users, but 9 times out of 10, they're going to be sexually what? Promiscuous, all right? That sexual promiscuity may be feeding their what habit? Drug habit, okay? So we need to meet people where they are, all right? Non-judgmental. I don't want to have to encounter this person in the emergency department and they are high on something and we can't get a good history from them and I'm accidentally stuck with the needle. I don't want that, okay? Not only am I protecting myself, but I'm protecting, I got a family at home, right? I need to protect my family. Perinatal. Again, it crosses the placenta. Prenatal teaching is important. Professor Brick can let you know for sure how soon after the neonate is born, if they test positive, when they can start them on medication. I don't know. I'm quite sure all of those medications are what's your vendor category for pharmacology? When it's not good for the baby.
Oh,
Yes.
see.
So they can't take them while they're pregnant, okay? So then that's a whole nother episode after that. But while they are pregnant and they are HIV positive, what things can they do to promote a healthy delivery? Safe sex, okay? Their activities, their diet, they need to eat healthy, they need to get some rest, those type of things. And we talked about all this stuff. Any questions?
I have a question.
Yes.
What was viral load?
Viral load is the amount of HIV particles within the host system. All right, this is something I wanted to read to you guys. I thought I highlighted it. This was in the paper from July of last year. And this whole poor guy's job is to hunt down and find people who have tested positive for sexually transmitted infections because then he's going to need to, oh, I'm sorry, not the court is still paper now. And encourage them to have HIV testing. So this is some of the stuff that I highlighted. In the last 5 months of 2011, the county cataloged 347 cases of chlamydia, 38 cases of gonorrhea, 81 cases of syphilis, and 5 new cases of HIV. This was the last 5 months of 2011. And according to this article, the rate of HIV infection is 3 times higher for Hispanics. And when we were talking about fear, there's even the immigration scare. Even Hispanics residing here legally are fearful of seeking services.
Why would they be fearful of their legal? Because maybe they have family members.
They may have family members that are illegal. Accessing the health care. So this little bright person in our state senate who wants the emergency department to track how many illegal immigrants we have coming through. First of all, my math don't go that high, and I'm not there for that. I'm there to treat people, okay? If we start doing that, they're not going to seek treatment, which means all of that stuff is where? Out in the community. I don't care. And I didn't understand that. Again, I'm from Wisconsin. I'm bordered by Illinois, Michigan, and Minnesota, and the upper peninsula of Wisconsin and Minnesota. I ain't know nothing about this. I didn't understand it until we started seeing people from Mexico. How do you get to Wisconsin? I don't know. She was 8 months pregnant. She drove from Mexico to Texas to Milwaukee to deliver her baby. So her baby would be a United States citizen. I didn't get it. I'm like, get them all. I didn't know. Again, you have to know what's going on in your community. Once it was explained to me, it was like a light bulb went off. You're right. We want them to come. We want them to seek medical treatment. What did we learn about TB? How long can that stay in the air? So if you have somebody with active TV walking around the mall, outside, it doesn't matter, in fries, it does not matter. And you walk through where they walk through, you're not supposed to what? TV. So if they are infected with HIV or some other sexually transmitted infection and they're here illegally and they can't get a job, again, remember I told you, it's the difference between living and surviving. What are you going to revert to? So if that's what they choose to revert to, then they are now doing what with all these infected processes that they don't even know they have? They're spreading it. Yes.
How long does TV stay in there?
How long does it?
Well,
Days?
you know, within a given 8-hour time frame, you know, you're not letting it spread out. So I've seen places where people have broken the chain of the microbes. They're letting it spread out. It stayed. Someone visited at 4 o'clock in the afternoon, and then 2 days later, this person was saying that, you know, the physician they went to because they heard their family member have the disorder. It can live. It's virulent. It can live.
And if it doesn't die in the air, we're finding that things live on the surface,
Yes.
hard surfaces for 2 weeks. And
long
there's a
time.
strain of TB out there that is virulent also. So, but something else I found very interesting is that he was talking about our senior citizens. He said, I brought lots of condoms. Oh, this is cool. Still Johnson does not leave out the older crowd when speaking about safe sex. This past March, he set up an information booth at the Central Arizona College Senior and Family Health Fair. I brought lots of condoms, he said. I talked to a broad range of individuals. I was speaking to senior citizens. I was speaking to families. Maybe he told them about the immodest Apache Junction couple. They were clients in a case he handled several years ago when he worked for the Maricopa County Health Department. They were in their early 70s and they were swingers. Johnson said that's how he actually put it. We're swingers. Being swingers, they freely had sex outside of their marriage. The husband, after one such encounter, went home and had unprotected sex with his wife and treated both of them. So, make it clear for you. So he said he was talking to families and he was talking to the elderly, our teens, fastest rising, persons of color. That article was July of 2011. How long ago? 2012. How many months ago was that? And at that time, Hispanics 3 times more likely. What part of the country are we in? Any questions about anything you learned from this lecture, be it on Friday or anything that we talked about today? So the majority of this, what do you think your questions are going to be about? Instead of me giving you questions, I want you to tell me what are some possible test questions that you can have. Yes, your tree. Yeah. So what kind of questions do you think you can have based off of that tree?
Give us like a vaccine room or use an anti-venom vaccine. What type of immunity?
Okay, what type of immunity? Now let's take that a little bit further. What other questions do you think you can have?
I know.
What?
You said. They stepped on a rusty screw. And then they got their TVs. No. They got their tetanus shot in the emergency room. What kind of blood would this be?
Oh!
Ready.
I didn't know how crazy he was.
And your answer would be, oh, blah, blah, like you said. Alright. Or you could actually have some matching. So you need to know it both ways, right? Okay. What else did we talk about So, what did we talk about in inflammation?
I can see one. Inflammation does not always mean there's infection.
All right, and we had
See
some
something
signs
with
of
that.
inflammation, didn't we?
Pain.
Okay. You also learned about inflammation that did not have an effective process, right? What were those?
Allergies.
Okay.
Heart
So,
attack.
more or less from these questions, some of them will be kind of straightforward, like Greg and his blah blah. Okay. Some of them could be matching, right? Some of them could be teaching. Where do you think the majority of your teaching questions are going to come from? What material? All right, so your STIs and your HIV lecture. So somebody give me a question about teaching, but we want to make sure the patient understood your teaching.
Which one of these would let you know that your patient understood the ways that they can protect them from HIV?
All right.
Or what we would require
Yeah.
Okay, let's hang right there for a minute. So, what are some responses that no, they understood what you were saying? Abstinence. Use a latex condom. Spermicides do not kill HIV. And what's one that you know? Ooh, we got to spend a little more time on this.
I can use a lamp.
All right, I can use a lambskin condom. Is that not on the taboo list? All right, so this is
real thing.
that is
People without like electric allergy are supposed to use like lamps and condoms.
You're so bizarre.
okay. Get off the baby sheet. Get off the baby sheet. We also talked about.
We're not going back.
Like ordering them.
Get it all out. Get it all out. Get it all out. All right. We also talked about allergens as it relates to genetics. Can they be passed along?
Yes.
Yes. Also talked about your different types of allergic reactions or responses of hypersensitivity. What is type 1?
Rapid.
What's type 5? What's type 4?
Delayed.
I don't know. Look it up in your book. Stimulated. 3.
No, that's 2.
All right, and 2 is.
Cytotoxic.
And we learned that cytotoxic is what? The RH.
Stimulatory would be like Graves' disease. Hyperthyroidism.
Oh, hyperthyroidism.
That's what it says. Yeah.
So stimulated. Hyperthyroidism / Graves' disease. And anaphylaxis is what? What causes somebody to go into anaphylaxis? Allergies or the
Allergic reaction.
so they were exposed to what's the word I'm looking for? Allergen.
And
An allergen which produces the whole reaction, the response, the inflammation response, right? So all of this kicks off because something was introduced to our body that our body did not like. Who arrives first? Who shows up to the party during inflammation? Who's first? Neutrophils, okay? So you know that neutrophils come first. They're never late. They come bearing gifts. Give me an example of, well, tell me what is active immunity? What does that mean?
The body actually responds.
Okay. What is passive immunity?
Transferred to the body.
All right. It's transferred to the person's body. Where is it created?
Somewhere else.
Somewhere else. All right. Animal or a person. All right. Active natural. What does that mean?
Exposed.
Body makes antibodies.
Without human assistance. All right. So we kind of harped on those chickenpox parties. Nobody should actively seek out to get infected with some microbe. Okay. What is artificial? What is active artificial?
Vaccines.
Vaccination. All right. Passive natural. Breast milk.
Placenta.
Placenta. All right. And then your passive artificial.
Tetanus, rabies, the antivenoms.
Okay, we talked about that HIV virus. What is the genetic makeup of the HIV virus?
RNA.
RNA. What is the little ingredient it uses to handle its diabolical business?
Reverse transcriptase.
Reverse transcriptase. Awesome. When teaching about HIV and STIs, your teaching should be what? The
Specific.
patient, all right? So it should be population specific, right? What is viral load? What is your T cell count?
Less than 200 is for AIDS diagnosis.
It should be more than 200. So your T cell count lets the healthcare provider know what? How many healthy T cells are running around the body? If it's less than 200, that person has what?
AIDS.
Can you go from AIDS to HIV?
No.
All right. Opportunistic infection. What does that mean?
Your body can't fight it off.
All right. So our AIDS persons usually die from an opportunistic infection. Give me some.
Pneumonia.
TB, pneumonia.
That's what I was saying.
Cancer.
Say it again.
Carcinosis.
Carposis.
Kaposi sarcomas. Yeah.
It's like a MRSA.
MRSA staph, a yeast infection will take them out. So they usually die from something
It's Kaposi.
other than their HIV status because their immune system is what?
Compromised.
It's beyond compromised. And I think basically that's what I'm going to be. Want to do yours? Remember, there's no class on Friday. And you have no skills lab on Thursday. So lucky Wednesday can go.
Roughly what time are we doing it? At 9 o'clock.
No, we won't. Our time is our time. We don't have skills lab and we need to be there full time. How many of you plan on showing up on Wednesday?
How many plan on showing up?
For the study session.
Oh, I'm like, do we have to go to
Wednesday, let's go. This does not apply to you.
Okay.
Well, I got everything here. If you feel you still need to come, you're welcome to come. Let me know, because I will be somewhere else.
Okay, hold on. What I'm going to do is put up some study guides. I am not posting the answers because we want you to get in that book and find the answers. If we give you the answers, you're going to study the answers. Again, I was a student and I had teenage sons. They taught me all the different ways to get around actual learning. So, you're going to have some respiratory stuff up there for you to work through. You're going to have some immunity stuff for you to work through and use those as the guides. Yes, ma'am.
Do we need to know, like, you said to look them up, the cell-mediated immunity, like, I know you said neutrophils are first,
Yeah.
but do we need to know all the other ones, basophils and eosinophils and all those?
Yeah, you should be familiar with them.
Okay, let's get started. I want you to know that I was hypoxic. I'm coming in up here.
You're restless.
I'm restless, confused, short of breath. Okay, so hypoxic signs. Confusion, possibly, as a later sign. Anxiety may be first. Also with me, if I was very compromised, what musculature I would be using?
Accessory muscles.
Accessory muscles in the neck, intercostals. You can't see my intercostal. That one, okay? Therefore, you're not going to see that. You're not going to see it even if it's been heard. So, you're going to look at mentation, looking across the room. You're going to see some anxiety, possibly, maybe some confusion, which is a late sign. You may see some accessory muscle use. You're going to see activity intolerance. My tolerance might be I'm holding on to everything like Fred Sanford. I can't breathe, for those who may know him. And, I just can't get from one point to the next. What will my heart try to do to compensate?
Speed up.
Faster.
You're going to have tachycardia because the heart's going to try to put out more blood supply to help. On your labs, why is it important to look at on your CBC this isn't a test question, but I'm just going to see how you guys understand it. The MCH and MCV. Remember? Immature red blood cells, because your body needs it. So those are going to be elevated. That's not a test question, but other stuff. Okay, what would be some signs that I have chronic respiratory depression?
Clubbing.
Clubbing of the fingers. You might see all those signs again that you saw before.
Barrel
But
chest.
what's that?
Barrel chest.
Barrel chest, if it is emphysemic. So clubbing, remember clubbing. Capri fill may be delayed. So if I come in here and I'm walking around like Fred Sanford, I wish someone would give me a chair, because what are you trying to do? You're trying
Increase your activity.
conserve energy, conserve that O2. Then you give me some O2. You've assisted, you put me upright, you set me down, give me some O2. This is a hospital
2
setting.
liters. How many liters would you like to give her?
No.
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 15. Now she's symptomatic. Okay. So why was 2? You want to help her out, right? Can we give her more than 2?
Yeah.
How much?
4.
Okay, and then titrate
Until
down.
you know
Right.
what's going on. Okay. So conserve the O2. Give them O2. The only disorder we talked about that you need to watch for, but if they're in a pre-code situation, give them some O2. Then you want the main thing we said with emphysema is 2 liters, because you don't want to give too much O2 because it'll kick out that dry breath. Okay. All right. Now let's talk about pneumonia. You know that pneumonia can be bacterial, viral, or fungal. If I acquired a nosocomial pneumonia, where did it go?
The hospital.
Some hospital or medical setting. What is the main way, no matter what setting you're in, to prevent that transmission? Hand washing, basic hand washing. Okay. Patient says to you, I got pneumonia. Why aren't they giving me some antibiotics? What are some other things needs to be looked at?
Viral.
It could be viral.
Viral.
If you give them some type of broad spectrum antibiotic, it's not going to help them. Okay. It could be fungal. Okay. What would you tell a person to do other than hand washing to prevent the transmission? You want to shield your coughing, because it's just a spray that occurs. If you're sick, you're sick.
Stay home.
Don't expose other people to that. What do we do in the hospital to prevent or assist in preventing someone acquiring pneumonia?
Wash your hands. Vaccination.
You want to encourage them to yearly get the pneumovax. What age groups are more prone to, you want them to get
I
that
thought it was
pneumovax?
5 years.
Yeah, I thought it was 5 years.
What?
5 years.
Okay, but pneumovax, what age group?
Elderly.
55.
Huh?
It's 55 and older, but Shirley said something key. If you're immunocompromised, so like your asthmatic, your population we just just talking about your HIV person.
So you want to teach that preventative measures. It's not the time to go out in a crowd when you know it's high prevalence. Okay. With pneumonia, you know, we talked about community acquired versus hospital acquired, which is the most common. Here is some key measures, core measures. We have a PowerPoint on core measures. How would you know your patient understood the core measures? Remembering the core measures were things like pneumonia screening. You look at certain target groups, like the elderly and the young. Okay, there are preventative measures that you do in the hospital. I kind of digress from that and then cover it completely. Someone who's post-op, you have them use the incident spirometry. You get them up early. You have them drink fluids because if mucus collects, what are you having them do fluids? Why are you having them do fluids? Liquefy the secretions if there's any so that they can then expectorate. Okay. Okay, pneumovax screening. If they're in the hospital setting, you want to give them a O2. It may be initially conserving that O2 demand, which may be having them on bed rest with bathroom privileges. It's not the time to walk them 3 or 4 times around the hospital perimeter inside. O2, pneumonia screening, blood cultures. If they needed a sputum culture, what's the best time to obtain that?
Morning.
And take it to the lab when you get it. Okay, cigarette smoking cessation. You know that people aren't going to quit, but what would be a goal for someone to do? Huh? Yeah, if they're smoking a pack a day, you need it personal toward that patient. Maybe their goal is if they're taking a pack a day, that they will limit to half a pack, because they're not going to quit cold turkey. Matter of fact, they know that the smoking is compromising. And why is it compromising? What does the nicotine do?
Constrictor.
Vasoconstricts. They're not getting that oxygenated blood. So therefore, you want them to decrease, hopefully that the goal is that they will stop smoking altogether. So that needs to be addressed. Also, antibiotic therapy needs to be started. How would you know that your patient needed further teaching relative to antibiotic therapy?
It's starting when they feel better, yeah.
Oh, I feel much better. I'm doing good. I'm walking a mile. Yeah, and so they stop their antibiotic therapy. So what would be your response to them?
Take it till it's gone.
Take the whole dose, because what will occur if you don't? There might be a resistant virulent strain that can occur, and the microbe will grow. Okay. Now let's go to sinusitis. How would you know I have sinusitis? By looking.
Congested.
There'd be maybe some edema that sets in. I'm saying, oh, I feel so stuffed up. Pain upon palpating the sinuses. What are some things that will perpetrate the sinusitis to occur in the first place? Dust, smoking,
Seasonal changes.
seasonal allergy, all those irritants. So when the person gets up in the morning after resting at night, they may have some congestion in the nasopharynx area. What can help them? Broad group of medications. Maybe some steroids to decrease inflammation. But what's
Decongestant.
going to happen? I heard it.
She said decongestant.
Decongestant. So, some type of steroids to decrease the inflammation.
Is antihistamine, I guess it's not the same as the decongestant.
No. But an antihistamine might be needed because if the trigger was an allergen, seasonal, whatever, you might use an antihistamine. While we're talking about antihistamine, what is a side effect of taking the normal side effect of drowsiness? Let me discuss that. What could you do independently to assist with that decongestion? Increase fluid. Do you have a question back there?
Do we need to look at a table or something to know exact meds?
No.
names?
No, I know y'all. You need to look at it as a group. And what is it the man's gonna do? What is an expected outcome?
Wait a minute, is it a table in your book?
There may be a
Every
table in the
chapter's
book.
got a drug table.
Meds listed, so I
That's
know
what we talked
med
about.
names.
You need to know the group.
Like ACE inhibitors or beta blockers.
If that was the case.
Yeah.
But we're talking about respiratory, so you need to know what decongestion is.
So you know, like your bronchodilators and all those, right?
Okay. So.
But we need to
decongestion.
know specific, like, we know albuterol, but like, is there gonna be anything obscure on there?
You're
No,
just very
no,
in
no,
pharmacology.
no.
You're just very in pharmacology. It's a broad group. Let me just tell you, decongestants. They're going to get that congestion, decrease it, but you do adjunct therapy by increasing fluids so that they can liquefy those secretions. Now, antihistamine generally given as a broad group to decrease that allergen effect, that if it is seasonal allergies, things like that. And the reason why they have that inflammation that occurs is because of the allergen that's activated. Okay, also, with sinusitis, they may have the postnasal drip. It's an itis, so what are they gonna give them? Antibiotics, possibly.
Okay, hold on. Itis equals inflammation, correct?
Itis can be infection. If it's a known infection, so what are you gonna obtain besides sputum or whatever? There might be a swabbing. They identify the microbe, but before your results are back,
Broad spectrum antibiotic.
broad spectrum antibiotics. How would you know systemically that that person, other than the cough, has some systemic problem? Like
Fever.
fever. When you look at them, they're flush. What labs are you going to look at? CDC.
What case would you give a steroid? Like, I know a lot of times with respiratory, they'll give a steroid, but in addition to a bronchodilator, block.
Okay, we're going to do that. Okay, one thing about if they're giving steroids, I'm not talking about inhalers, but if they're given steroids orally, what might the patient complain of, which is a side effect? Waking, irritability, and anxiety, GI, irritability, GI,
Hunger.
disturbance. So, irritability possibly, GI disturbance, nausea, vomiting. It's a steroid, so decreases the immune system. So what do you need to tell this person if they're on steroids? It's not the time to go to cowboy and Indian days here in town. You know, you don't want to expose yourself. Your immune system is down. You don't want to expose yourself to a lot of microbes you don't know who
Go volunteer in your kids' class.
Okay. And remember Exhibit A, Professor Bethune, when she was up here, she told you her triggers. It's where she lives. She, yeah. Okay. So, it's dust, and she has allergies anyway, so a lot of things there. Okay, then let's move on to, talk about pneumonia, sinusitis. Let's talk about the COPDs, emphysema. What is meant by barrel chest? What's going on? Huh? They become barrel because what part of the respiratory system is distended? The alveoli. So they want to breathe, and how are they breathing, and why? First lip, they're breathing off what?
CO2.
The CO2, trying to, so they're kind of like, what did she say the analogy was? Okay, smell the roses,
Okay.
first lip breathing. Okay. There's a gas exchange problem there at the alveoli area. Over time, the alveoli become distended, they lose their elasticity. If you were to listen to these lung sounds, the lung sounds of this person, you would hear what? You might hear wheezes, and if there's if it's dependent, you get them up in the morning, there may be cracks. Okay? But wheezing, because that air is trying to get out. They're orthopnic, meaning you have to sit them up. They may be leaning over a table. So, these individuals at times may have an inhaler also. Okay. You have your bronchodilators, which helps with oxygen saturation getting to lung tissue. What is meant by a spacer? I didn't say it in class, but what would a spacer do?
Medication is there.
It enhances the penetration of the medication in the inhaler, bronchodilator. What might be a side effect of someone getting a bronchodilator?
Tachycardia.
Tachycardia. What is your expected goal when someone takes the bronchodilator?
Increased perfusion.
You want enhanced oxygenation. What would be a sign that you know they have enhanced oxygenation? Whatever was occurring, like the O2 stats are down, they're going to come up. They're using less accessory muscles. If you have to give a patient a bronchodilator and a steroid inhaler, how would you administer these two things? Bronchodilator first to open up the airway, and then you follow through with the steroid. What's so important for you to follow as a nurse independently relative to administering a steroid inhaler? Oral care. Oral care, why?
You don't get thrush.
They can get thrush, they can get opportunistic infection, because what does it do? It reduces the immune system, and then too, that's going right into the mouth. So an independent function is oral care that you do. How would you know how much bronchodilator, whatever the medication is, that person has in the supply? What are you going to tell? How are you going to test it? Water. Okay, it sinks.
Oh.
It's full. Okay. It's full like the fish on top. It's in. Okay. Okay. Also with emphysema, what are some? We didn't get into it too much, but what will the heart looked at the heart on X-ray, it would be enlarged. What is that condition called?
Cardiomyopathy.
Cardiomyopathy, because the heart's trying to compensate this person who's not getting enough oxygen. Even though it's enlarged, you can't get that cardiac output that. Okay, let's go to asthma. What two conditions are going on with asthma, or what can occur with asthma? Spasm and spasm, which could be the constrictive force, and there can be edema. So you may use the same medication, steroids, when someone has asthma situation. You're still going to use the inhalers. And what are the triggers with asthma? Allergies, same thing that can be with sinusitis. Or an emphysemic type flare-up. What is that word when a person just can't seem like they're not compensated? It's with an E. Exacerbation. And I've heard you guys say many a word to describe it, and it don't sound right. But you know, it's exacerbation.
That's what we're called, exacerbation.
Yes. Okay. That means, and that doesn't only go for respiratory conditions. It means that the person's not managing well to medication management. They're hospitalized. Okay. Bronchiectasis. How would the lung sounds? What would you ask the people? What would you hear? Bronchiectasis. What did you say? I'm stuttering. Okay. It's bronchiectasis.
Oh.
Bronchiectasis.
Remember extreme conditions, emphysema, asthma, bronchitis. Yeah, bronchitis. I got bronchitis.
I'm like, what's bronchi?
But the thing is, on the PowerPoint, it shows me this. What would you expect those up there up here? What do they sound like?
Asthma or with
Bronchitis. The B word.
Freckles and wheezes.
Yeah, say it. Yeah, that's the way I remember it. I don't know if they heard you, but
Bronchi and the
Hey, rough sounds, bronchi could be possible. There might be mucus that collects also. One thing about these that's common with these three conditions is there may be wheezing. We already said with bronchitis, bronchiectasis, you know how we said there's going to be some coarser lung sounds. Wheezing is prevalent with emphysema because of the trapped air. If they're retaining CO2, what metabolic condition might they?
Acidosis.
Respiratory acidosis. That's why they're doing the pursed-lip breathing. Okay. So the meds you should know is a broad group. It's steroid. You should remember that if there's some steroids, bronchodilators, there may also be, if there's some decongestion, there's mucus, and you're augmenting with fluid replacement, be it IV or orally. Okay. Now let's move on to TB. If a patient presented to the emergency room, what are some signs and symptoms that we would elicit them to tell us about? That may be
Bloody sputum.
night sweats, coughing up blood, which is hemoptysis. What else?
Weight loss.
Weight loss. Hemoptysis, night sweats, low-grade fever. Okay, that being the case, if we suspect that in that individual, what could we use on that person if we suspect we do not diagnose them yet, but there's a suspicion? How would you protect others from that person? Isolation. What do you know that medical personnel need to have been fitted with? A HEPA mask. Does they may be the one taking care of that patient when they get to the unit. What testing? Or some testing to determine if that person truly has TB.
Skin test.
A skin test, which is your PPD, a chest X-ray, sputum culture. What are we looking for? What are we looking for? In the sputum, we're looking for the acid fast bacillus. Best time to get that sputum?
Morning.
Okay. Now, with the PPD, if someone, just because someone has what looks like a positive, doesn't mean that it's truly positive.
No.
What could it mean?
That they got
Been
their
exposed.
Exposure?
or they got their vaccination overseas.
Yeah, if they got a vaccination overseas. Okay, if someone's tested positive, at one time, their subsequent diagnostic procedure would be chest X-ray. How do you measure for a induration? Okay. Induration on each side, redness, but induration. How's it measured in what?
Millimeters.
Someone's on steroids and they're getting a PPD, or they're ordered a PPD. Would you administer that TB skin test at the time? if
No.
you're on steroids? Because you're going to get a false reading. It's not going to be accurate. You want to wait till
Increases
they're
the
all
immune
negative.
response.
Yeah.
False negative.
Would that,
In other words, it's not going to be right.
right. No, I just thought of something else. Would that same premise hold true for someone who is getting allergy tested?
Probably.
So
So
allergy
they're
testing,
taking
steroids.
steroids and they're going to get any type of testing where you need to get a response. What would you do as a nurse if you found that out? Would you administer
Delay.
the test?
No.
No.
You need to wait.
So you need to wait.
So as a patient, you could just take a steroid if you know you're going to turn out positive. Right? I'm sure people do that. I'm sure people do.
Now,
Not saying anything.
as far as we talked about sputum cultures. What would determine someone's on therapy? We're going to get onto the therapy, but relative to that sputum culture, how many sputum cultures would they contain to determine that they're free of TB?
3.
3 negative sputum.
She did it on this one.
Okay, let's follow that same thing. They're in the emergency room. They're coming down the hall with a mask, a full mask. The staff that's going to take care of this person is wearing a filter mask. What type of room have they going to put this person in? Okay, because you want the air to get out to the public. Okay, what meds? Oh, let me just do it this way. You know there's several meds. INH, rifampin, and there's several of esmbutyl, all of them. Patient says to you, oh, I'll just have to take that INH. They need further teaching because what is the, you start with possibly 3. How long will this person have to take these medications?
A long time.
I mean, the duration can be up to 6 to 12.
Initial things?
Not initial, I'm just saying in general. In general, 6 to 12 months. And
Now-
you need to tell, go ahead.
Greg said something very key. Your first question was, there's a difference between the initial phase, how long is that?
8 weeks.
And the entire course, which can last up to how long?
12 months.
Year and a half.
A year and a half, 6 months, 12 to 18 months.
So you actually are positive. You do initial and continuation and prophylactic, or just initial and continuation? Okay.
But if you're talking about extended prophylactically, things. that medication. I know I just need it for my TV, and all of a sudden I looked at, go to the bathroom and it's orange urine. Am I bleeding? No.
Yeah.
It's a side effect. No side effect from that medication. Okay. What do you need to teach the family relative to TB? If one family member, their family member is in the hospital, what do you need to advise the other?
They all need to be tested.
Like thing too, like if you found out a family member were positive, could you clean it out or something?
You make a good point. It's by droplet form. Wouldn't you think that once you find it out, you want to clean everything in your house, get them tested, and start it. Trying to review here. Okay, we talked about the upper respiratory, which we talked about sinusitis. We talked about pneumonia. We talked about emphysema. We talked about asthma. And on the slide, it is bronchitis. COPD is the whole umbrella. And then we talked about TB. You can expect, relative to those, the meds, broad group, your steroids, or your anti-inflammatory, even side effects from that. You can expect to have questions on your bronchodilator as to the effects of it and what are some side effects. What's the purpose of a spacer? You can expect, relative to TB, all we cover diagnostic. What are we going to do to what is meant by the results of the TB? And what time frame do you want to read that TB test?
48, 72 hours.
I'm hearing 48. I'm hearing what
72.
48,
Doesn't your book give you parameters for different populations as far as what is a positive and a negative?
It does.
Yeah.
Reading. Go over that.
Core measures. You know, biggest thing that is modifiable on the part of the patient for prevention of pneumonia is what? Smoking. Lab-wise, you know, relative to disorders, there may be blood cultures, there may be sputum cultures. Specific to TB, you know, it's the sputum where we're looking for the acid fast facility.
When did you give your antibiotic for pneumonia?
After
or
the-
after the culture?
After.
You're
After.
prophylactic and then you can change it once you know.
So you give your antibiotic when?
After.
After the culture.
I think you can give it
So you
before.
get a culture, you start a back broad spectrum, and then the specific.
No, you get your cultures first. So if it's a blood culture, you get your blood cultures first. If you can get a sputum culture, then you get your sputum culture, and then you start your antibiotic.
Well, the
But
blood's gonna tell you exactly.
right.
You're already on antibiotics and you're seeing culture won't be active.
Okay.
So you get your cultures, you give them the broad spectrum.
Right.
and
Then you
the
wait for
cultures
the
come
results.
back,
Then you can give them a more specific
Oh, I see.
antibiotic.
Yeah.
Yes.
And
So
so
They
if
mean
it
like
can't
they're gonna be anything else.
No, so people, the disorders you need to zero in on is, if you look at sinusitis, it will cover similar signs and symptoms that occur with upper respiratory. Sinusitis, study that, but yes, you're looking at the others. But if you know that, it will umbrella the upper respiratory symptoms, and you treat the symptoms. Okay, with pneumonia, we went over bacterial, viral, fungal, the relationship of nosocomial to community acquired, what you see in the patient. There's going to be some dyspnea. There's going to be, on x-ray, you may have patches, or you might have a whole lobe that is affected. Core measures we talked about. COPD we emphasize relative to medications that are covering there, steroids, bronchodilators, decongestants if there's congestion in there, emphysema, asthma, bronchitis. Those are disorders. In general, you need to look at if someone's compromised respiratory-wise, how is it going to affect the body system? From this test, there is 5 now that leaves you with, and it's math you had before, types of math, and questions. And then that leaves 45. There'll be 23 from immunity. I kind of looked at the test already. And there's 22 from the respiratory. What students do sometimes, they study, get squeamish about the meds. We want to know if you knew a prototype or a type of med in a group, what would that med group do? Like, for instance, anti-inflammatory. Okay, it's steroid. You know that steroid does certain things. It can cause, working at the top here, it can cause a local type of thrush that can occur. It can make a person irritable. It can have GI disturbances. They can have they make it puffy. Also, what does it do to the blood glucose?
Raises it.
That is the focus of this test. And we trended it, and students generally do a little bit better on this test. When I say a little, some, I'm surprised they do quite well. But you know, our focus is that you understand it, study the meds we told you to, look at it from the standpoint that what are the disorders, how does it present to the patient, and what am I going to do? And you were answering correctly what you were going to do. With that being said, I would say to you also, you know in the back of your chapters where it has questions, go over those questions as it relates to the disorders we went over. The same, mine and President Dunn's. And from there, who's coming tomorrow?